Hey guys, I'm having some technical difficulties today, believe it or not. Yeah, shocking, I know. Um, I don't know why in my mind I thought, oh, I'll just get on LinkedIn and go live. Well, that's not how it works. So I set up a LinkedIn live event, but I can't go live inside of LinkedIn in the live studio. So I don't know what happened there. So I did something wrong. Clearly, it's user error. But here I am, regardless. So I am using my other software to go live. So hopefully, that's going to work. I don't really know. I don't really know what's going to happen, but I'm going to show up anyway, and I'm going to do what I had planned, whether or not it's working. So I'm gonna just make sure, there we go, that it's actually on LinkedIn where it's supposed to be. It looks like it. Yeah. All right. Well, this is the first rough start to Inside Excellence, which is just a kind of a leadership and operational integrity insights conversation. And so, something I've thought about a lot is like a lot of different hospices, a lot of clients that I have working on different projects and, kind of carrying different things, different initiatives, different challenges, working on different opportunities. And it's really, it's really nice to be able to kind of talk through that, share that with each other, like, maybe in some cases commiserate about hope. I definitely have a bunch of hospices who are commiserating about hope, but that's really not the topic for today, even though that's fine to do. The topic for today is kind of just talking about ideas and initiatives for quarter 4 that your hospice is working on, or that your leadership team is working on. And how to kind of leverage those things that you are working on and kind of make some traction. So I'll share some things today talking about, different things that I'm seeing hospices are doing, different opportunities, some survey things we're seeing. We do a lot of mock surveys, a lot of accreditation surveys. And so we do see a lot of things specifically that surveyors are looking at. We do a lot of ADRs and TPEs. And so right now we have some really, really challenging audits going on. And a lot of you are probably experiencing that as well. But just to kind of talk through what some of those things are, see how we can help each other survive those audits and have the best possible outcomes. So that was something I wanted to talk briefly about. But more than anything, this is just a leadership conversation. It's meant to encourage and add value. It's really not a official compliance update with a slide deck and conditions of participation review. I think, when I really kind of searched for how I could give value and how I could encourage hospice leaders, I know that we have resources. We have good resources. We have resources through CHAP and ACHC and CMS, and we have resources through other national consulting agencies that do survey readiness, compliance, and audits, do a really great job. I watch their updates, right? I'm not here to say that that's not valuable, but I think, we can only sit through so many 2-hour webinars about, the new COPs and walk away not really knowing how we need to change our operations to actually implement those things and see that those things are compliant and see that those things are, going to have positive outcomes for our agencies and for our organization. And it really helps to be around other leaders to do that. That was probably my favorite part of going to the Sono Hospice Conference, Sono Symposium last year in Mesa. And it was the best corporate. It wasn't a corporate vibe at all, which I loved, but it was the best corporate hospice conference that I've been to because I felt like for once I was like, wow, I'm really in the right room. Um, and they really shared a lot of like leadership initiatives. They shared a lot of insights about what they were working on and, some up and coming things like AI and how that's impacting privacy and documentation and a lot of things. So I really loved that. That felt like a really um, aligned thing for me instead of talking about, you know, the new hope questions, which I know everybody is working through. I decided that I felt like a conversation um, was a better approach for this monthly inside excellence agenda, if you will. But I definitely will talk about some trends and more about how those relate to leadership and systems and operational integrity. So thinking about, how we can be proactive and not reactive about um, our approach to compliance, our approach to operations, our approach to census, our approach to revenue, all of those things to me are operational excellence and operational integrity and, lead back to compliance and lead back to culture and compliance issues. So I think it really ties together nicely. Um, we're looking at a time in hospice where there's a lot of angst around these audits and around survey. We're seeing surveyors who are not trained in hospice show up to do hospice surveys. The last two surveys that I've helped agencies with, one of them had one hospice surveyor who had ever done a hospice survey before. That was their lead, and that was a social worker. And then the other survey had no surveyors who had any hospice survey experience. They were nurses, they had long-term care, nursing home survey experience. And so they surveyed that agency like they would a nursing home. And if you have any background in long-term care like I do, seeing the differences from long-term care surveys to hospice surveys, it used to be long-term care surveys were extremely detailed, in-depth. They want to see preventative. They want to see anticipating needs, they want to see plan of cares that support anticipated decline, anticipated risks. And hospice was never that way before, and it is now. And maybe in part because some of these surveys are being done by surveyors who don't have any hospice background, have never surveyed a hospice before, and they're desperate to have surveyors to get these surveys done in time. I don't know. That's just kind of my take on it. That's a personal take, hot take there. Could be a lot of other reasons. The way that we are seeing the regulations go, it does definitely seem like they are trying to go more stringent and looking at more aggressive documentation for hospice patients. And it's been going, that's not a new trend, but it's definitely something we're seeing translating over to surveys. The last couple accreditation surveys, we have seen not just ACHC, but CHAP, both of them, the last two accreditation surveys, one was in September, one was in October, that we've been a part of with our agencies that we support, have been extremely in-depth and really, really splitting hairs in some ways that we haven't even seen before. So we're definitely seeing that the survey approach is definitely continuing to be really, really intensifying in a way that it maybe wasn't before. We've had a recent agency that we were supporting that did get a conditional tag for wounds. We have an agency that we are supporting that almost got a condition level tag for their volunteer program. So, they had to fight tooth and nail in order to not get a condition level for their volunteer program. And this is post-COVID, where we, just recently in the last few years had waivers for, the inability to get volunteers. And, these agencies are expecting that has been completely resolved now in 2025, and that you have a normal functioning, fully functioning volunteer program with at least 5% of your total patient care hours being supplemented with volunteers. And that's 100% back in full swing. And they are not, if you don't have the documentation to back up your efforts, they're definitely not taking any excuses there and not going easy. So they actually looked at the administrator and director's calendars to see, they wanted to see where they had gone, what dates they had gone, and what volunteer recruitment efforts they had made from the leadership team in addition to the volunteer coordinator, because they were not at their hours. And that is how they ended up not getting it a condition level tag. But that's not really something I have seen before. The volunteer program, I do see that agencies don't meet the 5% sometimes, and they're, working on that program and focusing on that program. When I was the director of operations, we didn't always meet the 5%. We had months where, we had little volunteer interaction, or we had a point in time with a leadership change when I came in. And then when I moved up to corporate and we had new director and a new volunteer coordinator, or we had volunteer coordinator turnover, and we had those hours drop. And so I know that it happens, but I've never really seen that much action taken in a survey on it, just past like a deficiency or a, hey, I've seen surveyors say, I need to see your recruitment efforts, I need to see your reports. But in truth, they didn't, come back in a way that was like, no, this isn't enough. I haven't seen that until now. So we're definitely seeing a more aggressive approach to those survey outcomes. Plans of care are always up there on those. We're still seeing that those plans of care are a huge focus, and that they do want to see more specifics than maybe usual. So, like I said, whereas before they weren't wanting to see necessarily like anticipatory things or preventative things, they are wanting to see those now. So they're wanting to see us preventatively address falls. They're wanting to see us, and a lot of agencies are already doing this, but not all agencies. I do see agencies who their care plans are very basic. They have the basic things that present on admission, but they are wanting to see more than that. They're also looking really carefully at orientation, and a lot of agencies don't have a super structured orientation program, or they don't have clear outcomes for their orientation program. So if there's not a structured way to approach QAPI in your orientation program, there needs to be. And if there's not, a really clear hospice disease management component of your orientation, there needs to be. So we're seeing them really drill down into the content of orientation for hospices. So that was a recent tag that we saw, that they did not accept what the agency had for those two areas. So what else? I'm trying to think of anything else. The usual supervisory visits and frequencies were both tags in both surveys. And then I'm trying to think of anything else that's relevant. Wounds are really big right now. So looking at your wound program, clinically and how that translates to compliance and quality of care, because they are starting to look at, okay, what processes do you have in place? What are your wound protocols? Are wounds getting regularly measured and updated? Is there a skin breakdown plan of care? And honestly, if your patient is bedbound or in a chair all day and has a terminal diagnosis and comorbidities, at this point, we may as well have a risk for skin breakdown on every single patient, unless they're, a walking, maybe cancer patient who is up and around. And then, at the point where they decline, you add a risk for skin breakdown when they're in bed, right? So that's one way to approach that. But we are seeing that they want to see those care plans: risk for skin breakdown, risk for falls, risk for bleeding if they're on aspirin or anticoagulants, which that's pretty basic. I do see that most agencies have that, but not all agencies. Risk for bleeding and bruising, those things like that, if they're on an anticoagulant or if they're on high risk meds, if they're on antibiotics, they want to see those care planned. They want to see those risk for care plans that we haven't always seen in hospice, especially related to their comorbidities and, activities of daily living that could be impacted by their terminal diagnosis. So we're seeing a lot of that. So things we're working on. What are some projects we're working on right now? We're working on, we're doing some really fun projects in addition to the not so fun projects, which we had a really large ADR that we just finished that was 250 claims and only 10 patients. So these were long length of stay patients that they pulled 10 patients, a total of 250 claims from those 10 patients. And they were each individual claims for each benefit period. So we are looking at doing a lot of long length of stay education on documentation, how to capture that decline, what to do if you don't have decline in a benefit period and you're, keeping patients on service for long periods of time and you're concerned about eligibility. These audits are definitely more prevalent now than ever, and they are denying these claims. Even when we provide substantial documentation, especially on technical denials, where we even have an agency right now who is getting technical denials for not having face-to-faces for benefit periods. They had multiple technical denials for not having face-to-faces for benefit periods that they have and were submitted and were still denied. And we appealed it and pointed out that the face-to-face was present for that benefit period and it was still denied. So we're seeing some really frustrating and frankly unfair seeming tactics right now from some of these audits that we are having to really fight all the way to the end to support these agencies. And we are seeing some of those be approved. And that's really exciting when we see that we're providing the documentation that this patient is eligible and that, this patient needs to be on hospice, that medical necessity is there, and seeing that those are approved. That is really exciting because those are the patients that really need our care, that, are hospice appropriate and that we're having to fight to care for. I need a drink of water, sorry. So those are some of the less exciting projects, but they're needed. These agencies need this support with audits. But the other exciting projects we're working on are building orientation and education programs. So we provide CEs so we can create, kind of bespoke is the coaching word, I think, like a highly individualized and tailored package of education on a topic or several topics, or as a supplement to onboarding and how to document decline, how to care plan, how to really care for dying patients in a holistic way, how to understand hospice for a nurse who's only worked in the hospital before. What is the difference? Just some really exciting topics on education that we can add nursing CEs to and provide for agencies to improve kind of their education programs, as well as doing like some bite-sized education. That's really fun. Instead of doing long, drawn out 2-hour recorded over slides, we can do some really fun, interactive, bite-sized education, um, mini courses or micro learning, fun things that we're seeing. Like I think MedBridge also does micro learning in their platform, and they have short, maybe 15-minute mini courses that you can do a burst of micro learning. I love that. I think that's really cool. And we have some agencies that want to do their own tailored, curated education instead of having, something that is really not branded for your agency and really not curated for your agency. It's just a generic hospice training, which there's nothing wrong with that. That's what there is out there. That's what's available, right? But they're wanting something that is really going to be deeper than that and speak to their agency culture and be more personalized than that and be more authentic to the care and service they're delivering. So that's really exciting. I love doing that. That could be we have some doing that on compliance and QAPI. I'm seeing that a lot of agencies, especially agencies that are small and privately owned and starting up, the leadership, especially the nursing leadership, is not used to running the QAPI program for their hospice. Maybe they came from a larger company where there was a QAPI and compliance nurse who did that. And so they're not used to having to be accountable for how to track and trend data and how to make a chart that shows what was audited and what's the trend and how to organize that information. So we have a free CE training already on QAPI for regulatory review. And so we're able to use that to kind of help organizations and agencies build a QAPI program that really is compliant, but also is going to suit their needs, because a lot of the training on QAPI that's out there is a little overwhelming, or, when we talk about the compliance requirements, it's not practical and we don't understand how we are supposed to be implementing that as leaders. And so it's like, I want to be compliant with my QAPI program, but I don't really know how that looks as a small agency, and I can't do all these things, and I don't know how or don't know where to start. And so we're able to kind of do that one-on-one with the leadership and build out a program that's really going to work for them, based on what their policies are, based on what their issues are that they need to be looking at, and what are the high-risk areas that they're concerned about. And so we're really excited about helping leaders build practical programs that are really going to be able to be useful for them and to really reflect the quality that they're delivering, because a lot of these agencies are delivering super high quality care, but they're struggling with reflecting that in their programs and reflecting that in their compliance oversight, because they are so ingrained in the clinical delivery and supporting the clinical staff and the day-to-day operations. And especially, me as a clinician, as a nurse, when I transitioned into an operations role, my brain just did not. I mean, my brain was operational all along. I had been in other leadership roles. I just really didn't understand how to take that from one-on-one, either with a staff member or a patient and a family, to a larger scale and to a program level. And so that's what I learned, through corporate leadership and being over 30 hospice locations, was how to take that one-on-one level of learning and level of quality and level of leadership and accountability and mentoring and processes and compliance, and how to apply that on a more global scale to an organization that's growing and scaling. Because we know that that's how our organizations get revenue, is through census and growth. And we want to grow in a way that's compliant and in a way that reflects the quality of care that we're delivering. But that's a balance that we have to really focus on to make sure that we're doing both. So those are some of the things that we've been working on together with our clients, and just some really fun projects that we enjoy. We're looking at some staffing and productivity, like some structural integrity things, as far as we have agencies who, with Hope, especially the logistics of Hope and how to cover these SFVs and how to cover these HUV 1 and 2s, how to cover these visits that are triggered that are occurring on the weekend when we have, maybe a weekend on-call team who's not used to having scheduled visits and on-call visits, or maybe we need to shift the structure to having more weekend on-call teams. So we're looking at some labor analytics right now for some larger teams on how to kind of restructure that field staff versus support staff versus admin weight across the board, especially with Hope. We're seeing there needs to be more oversight on the schedule so that these SFVs and these HUVs do not get missed. They're not declining these visits or missing these visits, especially when there's only a 2-day window to get some of these done. And so we're really looking at operational integrity and structural integrity for staffing and labor, how to develop a new way to determine productivity when, we're adding time points in the visits. And so that's been a fun project to look at. That's been exciting for the agency to be able to see some of their productivity metrics, to be able to see some opportunities in their labor and productivity that's eye-opening for them, and see where they might have more positions to add, more support staff they can add, and how to move those things around so that they're still giving great care, but they're also having the extra oversight they need. And then I think the last thing I was going to talk about was the changes for the Indiana agencies. I'm working with several Indiana home cares, so private duty, non-medical home cares who are either getting accredited or switching to add service lines to add skilled home care. I'm also working with several agencies actually who are adding palliative care, so that for some of these long length of stay patients that we're seeing, if they're more chronic or if they're not quite hospice appropriate, they can bring them on the palliative care side, provide that extra community support as an extra layer, and then have that bridge to hospice when they're ready or when they're appropriate. So those are fun initiatives, adding new service lines to existing agencies. There's a lot of moving pieces to that, especially in Indiana, where now Indiana is in fact requiring the agencies to have that accreditation, like many other states do. So now those agencies that are home cares that are adding the skilled services and going to home health services are going to be getting their Indiana licensure, then applying for accreditation and having their accreditation survey. So some extra steps in there that didn't used to be in there. So they are being required to be accredited now. I think it's either July 1st, 2026 or January 1st, 2026. I don't have it in front of me. But those are some new requirements for Indiana. So my Indiana clients are navigating that. They're doing a great job with that. It's just kind of how does that look? So I've been talking with CHAP about that and about what they're doing to make sure that goes smoothly. It is July. It's July 1st, 2026. By July 1st, every Indiana home health agency providing skilled services must be accredited or CMS must be accredited and CMS certified for skilled services and home health. So that is a new change for Indiana agencies. And so, we're working with them on what is accreditation? How is it different? What do we need to do to be more proactive as far as what's the next level of survey for that accreditation? And, how many patients do they need to have cared for? And what do they need to have for their personnel files? So we're literally taking them through the survey process from start to finish to make sure that they're ready for that, and doing on-site mock surveys for those locations. It's always fun, especially for the home care. We really love working with the home care agencies because we feel like there's just such a family feel to that, and we just get to know their teams so well. We get to go do education on site, get to go do some audits, get to we look at charts, we look at personnel files, we look through everything, and just to make sure that that's going to go smoothly, that they're prepared for accreditation. So that's some other fun projects we're working on. I would love to know what projects you guys are working on, what initiatives you're focused on for Q4, what you're seeing in your audits and your accreditation. I love having these conversations with hospices as far as what we're seeing as trends. I love hearing it from you guys. I love hearing what your leadership initiatives are and how you're aligning your teams to approach that education component. We know that it's a balance between having a process for it and having the staff understand, have them the education for the process, but also feel like the why makes sense. As I work with really small agencies that are privately owned, that are one location, that are growing from 20 to 70 or 90 really, really fast. And then I work with some larger agencies. I'm probably about half and half at this point. Some larger agencies that go anywhere from 200 census to 2,000 census. And they're looking at either acquiring, merging, bringing on new agencies, adding new service lines, having, exponential growth, and then looking at, wait a second, we have these systems in place, but the staff aren't aligned with it, aren't on the same page, don't have the why, aren't here with the vision, because either they're new to hospice, they're new to the agency, they're newly acquired from another company, or there's new management, new leadership, new processes in place to support the growth. And so all these factors really affect how your staff are responding to what your processes are. So we've got these smaller agencies that just don't have the processes in place. They're focused on the patient care, they're focused on the patients. And because there's one person, if I'm the DCS, I'm the director of clinical, I'm doing literally everything. I'm doing compliance, quality, scheduling, I'm doing admission reviews, I'm doing the audits, I'm doing QAPI, I'm doing everything, right? And so I know what I have to do because I'm the only person doing it. Now, if I take a sick day or if I want to take a vacation, there's nobody to cover me and things just get behind and they fall apart, right? Or if I don't tell the staff because it's in my brain and I'm the only person that does it, then it falls apart because there's no system, right? The system is me, and that doesn't work. And so the smaller agencies struggle with not having a system. The larger agencies struggle with having systems and no buy-in. And so the staff don't understand why they're doing the system. And so they aren't compliant with the systems, and the systems fall apart and we miss things. And that's where we start getting into compliance issues on both ends for the smaller agencies that don't have the programs in place. And so, if the education isn't there and the staff don't know, there's no bridge there from, a compliant program to staff buy-in and education. Same thing on the larger scale agencies. If there is no buy-in and there's a process and people don't understand why they're supposed to do it, they haven't been educated on it, they're not held accountable for it, so they're just not doing it, that breaks down the culture, that erodes the culture, and then you end up with compliance issues there. So it's a lot of leadership, encouragement and oversight and consistency on both sides. And it's a lot of education and staff support and process oversight on both sides. And so that's really been our focus, is to kind of lean more into that leadership support. And we have found that to be very successful when we're working with the leadership teams. So we're working with clinical, we're working with operations, we're working with, the quality and compliance team for some of these larger agencies that have their own internal compliance teams. And we're kind of bringing everybody together to get back to the why we're doing this, get the whole team aligned on the vision, get the whole team educated on what the expectations are, and then have processes in place to make sure that everybody's accountable. So those are projects that when we see the outcomes and the improvement from that efforts, that's really exciting. And it can literally just change the whole feel of leadership for that organization. So we really really love being a part of those kind of projects, because they're super rewarding for everyone involved. So we really like doing those, where we can kind of see that real impact on the organization, on how leadership feels. It changes kind of everybody's approach and perspective on doing their job when we get to reconnect to the why and make things make sense again, and kind of, put processes in place that support everybody. So we feel really fortunate to be able to work with agencies to do that. And that's just probably my favorite part of consulting, is just being able to build relationships with the leadership teams and be able to support them in a way that, is removed enough to be external support, but relationally feels very close, and like I have the privilege to really understand what they're going through and be able to provide some really practical support that can help them feel like their jobs are doable again, or help them have something click that was really frustrating, or making them feel stuck or overwhelmed or behind, or making them feel like they were failing at their job. And so it's really great to be a part of that. So that's our first monthly Inside Excellence. I would love to have any questions that you have. I'm happy to kind of go over questions or feedback, or topics that you want to talk about, or projects that you'd like to hear about, or survey findings, care plans, education, any and all topics related to compliance and operational integrity. I am not an attorney, so I do not provide legal advice. I am not a legal compliance partner, unfortunately. I am a nurse, and so I do education, survey and accreditation, operations, process support, leadership and executive support for hospice and home care leaders. And I have really enjoyed talking to you today. I did put my email, if you can see the comments, I did put my email, Nina, Nena, at Heart Healthcare Solutions, down in the comments there as well, so that if you have a question, or if you want to provide me with some feedback on this series that we're doing, or questions or topics, I would love to hear them. I think it'd be super helpful. I'd love to have you come on live with me if you want to have a conversation. I'm super open to that. If you want to share what your organization is doing really well, if you want to share what opportunities and leadership you're focusing on right now, I would also love to hear that. So I'd love to have you as a guest, and we can talk more and share about what your hospice is doing. So feel free to reach out. You can also subscribe to Hospice Excellence, the newsletter on LinkedIn, for more updates.